Dr. Singh, thanks for joining us today. Welcome.
So let's start without much ado. We stopped at we started this reaction patterns around 2 or 3 weeks or 4 weeks back. I gave you a brief introduction of all the different reaction patterns, and then we went into each of the reaction patterns of how do you approach each of the reaction patterns. So we are done with the spongiotic reaction pattern and the psoriasiform reaction pattern, and now we move on to the next one. So for all these reaction patterns, as you know, all the slides are available online. So you can actually go and look at these slides online. And so the case 4, this is the clinical presentation of case 4. So what you see are these very characteristic lesions that are associated with lichen planus, which are these white shiny patches. So let's look at the histology. So what do we see in histology? So on histology, like I always say, start from the top. So on the top, you're going to see basket weave or just hyperkeratosis. Then you come to the epidermis where you see this hypergranulosis, which is almost wedge-shaped. So in this area, it's like a wedge-shaped hypergranulosis. And then the very characteristic feature of this reaction pattern is this inflammation. Now, one thing to realize that this inflammation is hugging the dermal epidermal junction. So you have to differentiate this from a superficial perivascular inflammation, which can also look like lichenoid. So in the superficial perivascular, the inflammation is around the vessels, and in the lichenoid reaction pattern, the characteristic feature is the inflammation obscuring or hugging the dermal epidermal junction. So when you have this inflammation that is obscuring the dermal epidermal junction, that is the prototypical feature of a lichenoid reaction pattern. Now, if you go high power, it shows you the features more nicely. You can see the absence of parakeratosis on the top, so hyperkeratosis, but no parakeratosis. The wedge-shaped hypergranulosis, the dense lichenoid infiltrate at the dermal epidermal junction, and then scattered dyskeratotic cells. So these pink cells, these pink keratinocytes that you see that have this pink cytoplasm, these are the dyskeratotic cells. And what are dyskeratotic cells? They are like apoptotic cells or keratinocytes that have undergone apoptosis. And why does this apoptosis occur? Because the lymphocytes are attacking the dermal epidermal junction. In different books, they have different names. Some call them apoptotic cells, some call them dyskeratotic cells, some call them Sivate bodies, some call them colloid bodies. They all mean the same thing. They all mean just dyskeratotic keratinocytes or apoptotic keratinocytes. This is a hallmark feature of any lichenoid reaction pattern because the underlying pathophysiology is the lymphocytes attacking the keratinocytes. So what is the diagnosis? So this diagnosis is lichen planus, which is, as I said, the prototypical lesion for a lichenoid reaction pattern. And in the initial part of the lecture, I had already mentioned that the lichenoid reaction pattern has two patterns. One is the interface dermatitis has two reaction patterns. One was the lichenoid reaction pattern, and the other was the vacuolar reaction pattern. So in lichenoid reaction pattern, how do you sign this case out? So lichenoid dermatitis compatible with lichen planus. And why don't you just call it outright lichen planus? Because most of the times you don't have a clinical history. And even if there are other conditions that can look exactly like lichen planus. So if this was a single lesion on the patient, then this would be a benign lichenoid keratosis. And if it is a rash, then it's going to be lichen planus. So if you don't have the history, it's better to just call it lichenoid dermatitis compatible with lichen planus. Now, what are the other diagnoses to consider when you see a lichenoid reaction pattern? So like I said, benign lichenoid keratosis is going to look exactly like lichen planus. You can have a lichenoid drug eruption, and then the other conditions that are commonly seen in dermatopathology include lichen nidus and lichen sclerosus. So in benign lichenoid keratosis, again the same thing that you saw in lichen planus. So hyperkeratosis, sometimes you might see some parakeratosis if it's a benign lichenoid keratosis. Again, the wedge-shaped hypergranulosis or increased granular layer, and then the characteristic lichenoid infiltrate at the dermal epidermal junction. You go high power, you see the same features: the lichenoid infiltrate, the dyskeratotic cells, the hypergranulosis, and the hyperkeratosis. So you need a clinical history to differentiate between lichen planus or benign lichenoid keratosis. Otherwise, you just sign it out as lichenoid dermatitis. And in the comments, said the differential diagnosis includes lichen planus and benign lichenoid keratosis. So this is just highlighting the dyskeratotic cells at the dermal epidermal junction. There's some pigment incontinence. Again, that is just because the lymphocytes are attacking the dermal epidermal junction, and the keratinocytes, they release the melanin in them. So you're going to see a lot of pigment incontinence. In a lichenoid drug eruption, what do you see? So again, the same features that you saw here basically in the lichen planus. So again, the wedge-shaped hypergranulosis, the lichenoid infiltrate trying to hug the dermal epidermal junction. But in a lichenoid drug eruption, you'll also see that it is some focally, it is like perivascular also. So you have the lichenoid infiltrate, but then you also have a somewhat of a perivascular infiltrate. But what is the characteristic feature? So any lichenoid drug eruption, any lichenoid reaction pattern that you see, what are you supposed to do? You go high power, and then you just move along the dermal epidermal junction. And what are you trying to look? You're trying to look for eosinophils actually. So if you see this eosinophils, if you see this eosinophils, then it is a lichenoid drug eruption. So whenever you see a lichenoid reaction pattern, you have to go high power and then scan the dermal epidermal junction, look at the entire infiltrate. And even if you see 1 or 2 eosinophils, then in the comment, you will again sign it out as lichenoid dermatitis C comment. And in the comment, you say because of the presence of eosinophils, this is most likely a lichenoid drug eruption. So the features are almost the same except for the presence of eosinophils actually. In lichen nidus, this is another lichenoid reaction pattern, but it has a very characteristic ball and claw pattern. The way it is described is ball and claw. So in this one, the lichenoid inflammation is limited to 1 or 2 rete ridges. So this is like 1 or 2, and once you move out of the inflammation, it's very clean actually. So this is called a ball and claw pattern. So this inflammation is the ball, and the claws are the rete ridges that are holding the inflammation in between 1 or 2 rete ridges. The inflammation again has the same features: a dense lichenoid infiltrate composed of lymphocytes, and in lichen nidus you're going to see a lot of histiocytes also. So it's a lymphohistiocytic infiltrate hugging the dermal epidermal junction, but limited to 1 or 2 dermal papillae. And then it is and the limitation is done by the claws that are represented by the rete ridges actually. So if you see this, then it's lichen nidus, and these are cases that can actually come. These are common things that you see in practice, and then as a resident, these are common things that you're going to see on your exams also. So because these are things that you can recognize at a snap actually, and those are the cases that are going to come up in your exam. They might either give you the histological image, or they may actually give you a slide to look at and make the diagnosis. And these are diagnoses that you can make without any clinical history or anything. So these are cases that you should know as a pathologist or as a dermatopathologist, because these are very common things that can come both in practice as well as in your exams. So this is just showing you the high power view of the lymphohistiocytic infiltrate. So a lot of lymphocytes admixed with histiocytes. In lichen striatus, now this is one of the other conditions that comes under this chapter of lichenoid dermatitis, but doesn't have a lichenoid infiltrate. So the only condition that does not have a lichenoid infiltrate but comes under this chapter when you read about lichenoid dermatitis is lichen striatus. And this is another thing that you have to recognize, like what are the features that can help you recognize this as lichen striatus. So if you start from the top, you're going to see this mild spongiosis in the epidermis. Now in this, the inflammation, although on low power, it looks like it is lichenoid, but if you look at it carefully, it is not truly lichenoid. It's not hugging the dermal epidermal junction. It's more of a perivascular inflammation. So you see this perivascular inflammation. In this one, the clinical presentation is very classic. This is a very linear lesion. So most of the times when you get this, the clinician is going to tell you rule out lichen striatus, because it presents in a very linear fashion along the lines of Blaschko actually. So because of that, the clinician knows that most likely is dealing with either some kind of linear reaction. So it could be linear lichen planus, it could be linear psoriasis, or it could be lichen striatus. And that is most of the times in the differential. So you don't have to so the important thing for you to understand is what are the features that will help you make the diagnosis and say that this is compatible with lichen striatus. So what are the features that you want to see? Like I said, spongiosis, a superficial perivascular infiltrate, but very, very characteristically, so you see this lymphocytic infiltrate, but the most characteristic feature for lichen striatus is the inflammation in the deep part of the skin around the eccrine ducts actually. So whenever you're thinking of lichen striatus, what do you want to see? Let's go back to low power. You want to see this inflammation very tightly coiled around the eccrine ducts in the lower part of the dermis. That is what you want to see. So if you see something that shows you some mild spongiosis, some dyskeratosis, a superficial and mid and even deep perivascular inflammation, but then which is very characteristically involving the eccrine ducts at the bottom of the biopsy, at the base of the biopsy. If you see all these features, then you know you're dealing with lichen striatus actually. So you need all these features to call it lichen striatus. The peri-eccrine lymphocytic infiltrate is the most characteristic feature that you want to see.
So, Dr. Singh, so we don't see mass of interface dermatitis and lichen striatus.
You won't see. So the clinical is going to help you a lot. Like this is a linear lesion, and that most commonly presents along the lower, around the thigh or the lower extremities actually. So the clinical presentation is very important. So if you see something and the clinician hasn't given you some clinical history, you pick up the phone and like what the mind doesn't know, the eyes are not going to see actually. So if your mind knows that maybe this is lichen striatus, you pick up the phone, call the dermatologist and ask the clinical. If it is not given you, ask the clinical presentation. Is this a linear lesion actually? And then you put 2 and 2 together that this is lichen striatus actually. But this is one condition that you're going to deal with in the lichenoid dermatitis chapter, which actually doesn't have the classic lichenoid inflammation at the dermal epidermal junction. But another condition that you can easily recognize if you know the features. And then the last condition is lichen sclerosus. This is very characteristic, has the lichenoid infiltrate, but in this condition, what happens if the lesion is biopsied? Initially, the inflammation is at the dermal epidermal junction, but as the lesion progresses, you develop this sclerosis in the papillary dermis, and the inflammation starts getting pushed below the sclerosis actually. So if if the lesion is biopsied after a certain period, the patient has not done anything about it, then the inflammation doesn't hug the dermal epidermal junction but is below the sclerosis actually. So if you go high power, you can see that there is a dense sclerosis fibers in that area actually, and the inflammation has been pushed below the sclerotic region. So you have mostly atrophic epidermis, and that is the reason many times this is also called lichen sclerosis et atropicus. And that is the only thing that is telling you that the epidermis is atrophic. But if you don't see that, it is okay. So if you see an atrophic epidermis, a very dense sclerosis that is hugging the dermal epidermal junction, and a lymphocytic infiltrate that is at the lower end of the sclerosis, that is the characteristic feature of lichen sclerosis actually. And this is another important association that you need to know with lichen sclerosis is 5% of these patients can develop squamous cell carcinomas, and that is another thing that the people who write the exam questions, they like to ask actually. So remember, 5% of patients with lichen sclerosis can develop squamous cell carcinoma actually. But once you see this under the microscope, it is very easy to recognize, and this is another common condition that patients present with. So this is one thing that you should also know. So I'm just giving you, like if you go into the chapter of lichenoid dermatitis, there might be 15 different conditions actually. But what are the bread and butter stuff that you're going to see in routine practice, which you should know as a pathologist, not as a dermatopathologist, but at least as a pathologist actually. And these are conditions that you're going to see in you might not see one every day or one every week, but in 6 months, you're going to get one case of lichen sclerosis definitely. It's not an uncommon condition actually. So you're going to see this, so it's important to recognize that what are the features of lichen sclerosis.
So this is the condition that we see in the vulva, is it?
That is the most common location, but it can present in other places also. Like it can present on the scalp, it can present on the extremities, but the most common location is the genitalia.
What will be the other differentials in this on histology?
Like if the most important differential in this is going to be morphia actually, because morphia also is a sclerotic condition, but in morphia the sclerosis is not limited to the papillary dermis. It involves the reticular dermis as well as the deep part of the dermis. So
there will be epidermal thinning or something?
In morphia, it has not been characteristically described, the epidermal thinning. The characteristic feature in morphia, we have a case that will come to, is the sclerosis of the entire dermis. In lichen sclerosis, it is limited to the papillary dermis actually. The other thing that, like if you really want to go into differential, amyloidosis might come into the differential, and other things which can look like pink structures actually. But they look very different from lichen sclerosis. So this is just a high power view showing you the dense sclerosis that is hugging the dermal epidermal junction. and the lymphocytic infiltrate that you see below the. So this lymphocytic, the level of the lymphocytic infiltrate depends on at the stage when the biopsy is taken actually. If it is a very early lesion, it's almost like a lichenoid dermatitis. If it is as the disease progresses, the inflammation tends to get pushed lower and lower, and many times it might completely disappear also. So the inflammation is not always there. You have to also remember what is always there is the sclerosis, and that is the reason the name is lichen sclerosis actually. So case 5. Very characteristic, these target shaped lesions that are involving the palm and then this lesions on the lip. So most of the time, if the patient comes to the dermatologist like this, he's going to give you a biopsy and say rule out erythema multiforme, because these are classic targeted lesions that you are going to see in erythema multiforme. So we already know what we are looking for actually. So what are the features in it? So erythema multiforme is the prototypical lesion for so like when we started off the lecture, interface dermatitis is the main reaction pattern that we are right now talking about. And why do we say interface? Because we are talking of things that are happening at the interface. And which interface are we talking about? The dermal epidermal junction. So interface dermatitis is when the main action is happening at the dermal epidermal junction. Now in that main action that is happening at the dermal epidermal junction, you have the lichenoid reaction pattern that we already discussed, and the other one is a vacuolar reaction pattern. So there are two main patterns in the interface dermatitis. So the main action is at the dermal epidermal junction. So in the vacuolar interface dermatitis, we'll come back to this slide. Let's go high power. So what in the vacuolar, you're going to see vacuoles at the dermal. So you are going to see that the epidermis, there's a lot of vacuoles at the dermal epidermal junction. So it's something like a moth-eaten appearance of the dermal epidermal junction, and that is what is characteristically called a vacuolar interface dermatitis. And the prototypical lesion that you are going to see in that reaction pattern is erythema multiforme. Now, erythema multiforme is a very acute reaction pattern because it is not like a chronic reaction pattern. The patient suddenly develops erythema multiforme to a variety of reasons. It could be to drug, it could be to some sort of viral infection, it could be idiopathic, but they develop these lesions very acutely actually. And that is the reason when you read about erythema multiforme, they talk about a basket weave hyperkeratosis. So this pattern that you see here is a basket weave hyperkeratosis. And what does that signify when you read about it? That is telling you that this is an acute reaction pattern. Because as the lesion is going to progress, if the lesion is chronic, the patient tends to develop hyperkeratosis, parakeratosis on the top actually. But you don't see that. You just see a normal basket weave hyperkeratosis. And the only significance of that is that this is a very acute reaction pattern. So that is the significance of the basket weave hyperkeratosis. So whenever you see a vacuolar interface dermatitis, the first thing that you want to ask yourself is, do I see dyskeratotic cells in the epidermis? So there are two things that you need to think about. So one, do I see any dyskeratotic cells in the epidermis? And secondly, if you don't see that, do I see any inflammation in the dermis? And based on that, you can narrow down the differential diagnosis. So first you have decided that this is a vacuolar interface dermatitis because you look at the dermal epidermal junction and you see this moth-eaten appearance. Now the second question to ask yourself is, do I see dyskeratotic cells in the epidermis? In this one, you can see there are tons of dyskeratotic cells. So if you see dyskeratotic cells in the epidermis, your differential diagnosis becomes very limited actually. Either you are dealing with erythema multiforme, or you are dealing with graft-versus-host disease, or you are dealing with a fixed drug eruption. That's it. Those are the only three conditions that are going to be in your differential. So once you put that thinking cap on and go in an algorithmic fashion, your differential diagnosis is going to become very, very limited. You don't have to scratch your brain what this is actually. So that is the importance of following an algorithmic pattern actually. So now, like I said, once you have decided lichenoid dermatitis, then your differential diagnosis was very limited. Either lichen planus, benign lichenoid keratosis, or a lichenoid drug eruption. That's it. You're not going to go beyond that actually. And then you just go high power and try to see what the condition is actually. So similar for vacuolar interface dermatitis, first thing, do I see dyskeratotic cells in the epidermis? Yes, I see dyskeratotic cells in the epidermis. So now your differential diagnosis is erythema multiforme, graft-versus-host disease, and fixed drug eruption. Now how do we differentiate between the three actually? So in erythema multiforme, like I said, that was the importance of stressing the acute reaction pattern. Erythema multiforme is different from how graft-versus-host disease because this is very acute actually. It happens very suddenly. So that is the reason you see the basket weave hyperkeratosis on the top. So if you see that, You see a lot of dyskeratotic cells in the epidermis. You see the vacuolar interface changes. Most likely this is compatible with erythema multiforme. We'll come to graft-versus-host disease and the other. And the other thing that you're going to see is this superficial perivascular lymphocytic infiltrate actually. And you might see eosinophils, you might not see eosinophils. If it is the erythema multiforme is related to a drug reaction, then you're going to see eosinophils. If it is related to a viral infection, you might not see the eosinophils. If it is idiopathic, you might not see the eosinophils. So eosinophils are not needed to make the diagnosis, but if they are present, they just tell you that the etiology most likely might be related to a drug. That is only important basically.
So TEN will not be in the differential diagnosis.
No, that is what we are coming to. So like remember, erythema multiforme is the acute thing. Now, and we saw the targeted lesions on the skin. Now, if erythema multiforme also involves the mucosa, then people tend to call it Stevens-Johnson syndrome. And if erythema multiforme becomes so extensive that the skin becomes to slough off, then it is called toxic epidermal necrosis. So it's all the same reaction pattern. It's the same spectrum of diseases actually. It's not like toxic epidermal necrolysis, Stevens-Johnson syndrome, and erythema multiforme. They are all the same disease entities. It is just the amount of involvement of the skin and the mucous membrane. You give them different names actually. So if you're just involving the skin and you see this, then it is called erythema multiforme. If you see mucosal involvement, then it is called Stevens-Johnson syndrome actually. Same histological features are still going to be the same, but it is called Stevens-Johnson syndrome. And if the skin becomes like sloughed off completely when the erythema multiforme is like developed to such a great extent, then it is called toxic epidermal necrolysis. So what do you see in toxic epidermal necrolysis? Same features, but now to a higher degree actually. So you're still seeing the dyskeratotic cells in the epidermis, but now they've almost come to a degree of confluent necrosis actually. So when the dyskeratotic cells go to a degree of confluent necrosis so that the entire epidermis looks necrotic and gets sloughed off, then it is called toxic epidermal necrolysis. It's still like you see the basket weave hyperkeratosis on the top, again the same features, but now the dyskeratotic cells become so extensive that the entire epidermis is necrotic and has sloughed off, and that is toxic epidermal necrolysis. And this is an important feature as a pathologist. This is very important to recognize because this is the only frozen that you're going to get actually. So differentiate between the only frozen in dermatopathology is differentiating between toxic epidermal necrolysis versus staphylococcal scalded skin syndrome. That is the only frozen that you're going to get in dermatopathology. And as a pathologist, you are going to get frozens, and whenever you're on call actually. And so the only thing that you need to recognize is how do I separate this from staphylococcal scalded skin syndrome. So the important feature to recognize in toxic epidermal necrolysis is there is complete epidermal necrosis. In staphylococcal scalded skin syndrome, which is a pattern of Vesicular-bullous, which we'll see when in the next reaction pattern, there is no necrosis. So this one, there's a lot of necrosis. So if you see a skin that is completely necrotic epidermis, then you're most likely dealing with toxic epidermal necrolysis actually. So this is completely necrotic epidermis, a lot of dyskeratotic cells. So that is toxic epidermal necrolysis. So like I said, in the vacuolar interface dermatitis, the first thing to ask yourself is, do I see dyskeratotic cells in the epidermis? If you see that, erythema multiforme, graft-versus-host disease, fixed drug eruption, that's it. You don't have to think anything more actually. If we don't see the dyskeratotic cells, do I see perivascular inflammation in the dermis? If you see that, then you're dealing with connective tissue disease. So like once you've decided I'm dealing with a vacuolar interface dermatitis, that is the only list of differential diagnoses that you have to think of actually. So if you follow a pattern, your list is going to become very, very small actually. So in a graft-versus-host disease, again the same pattern you're going to see. So what we said, vacuolar interface changes at the dermal epidermal junction with a lot of dyskeratotic cells in the epidermis. So same differential diagnosis like erythema multiforme, but this one now is not an acute phase. You can see that this is more hyperkeratotic and more parakeratotic. And the very classic thing that you want to look for in graft-versus-host disease is follicular involvement actually. So if you can go through the biopsy, and if luckily if you have a follicle there, the main place to look for dyskeratotic cells is in the follicle actually. So if you want to go around the biopsy, many times you might not see the follicle there actually. So vacuolar interface changes with dyskeratotic cells which are not as extensive as erythema multiforme, and more hypergranulosis and hyperkeratosis on the top, most likely this is going to be a graft. So whenever you're thinking of, am I dealing with erythema multiforme, graft versus host disease, you're not going to sign the case out without getting clinical input. So you have to pick up the phone, or you have to talk to the person who sent the biopsy. What are you thinking actually? And once you have this feature, you have the clinical picture, the diagnosis is going to be very, very easy. So if the patient has a bone marrow transplant, and they are low, and they have done a biopsy because the patient developed a rash, then you know that you're dealing with acute graft versus host disease actually. And so what these, you have to remember what are the features that are consistent with graft versus host disease. So vacuolar interface changes, discretotic cells in the epidermis, and if you see a follicle, luckily, then involvement of the follicle with the discretotic cells. Another characteristic feature that many books are going to describe in this vacuoles. So do I have a high power here? Let's see if we can. So if you see this, all these vacuoles that you see at the dermal epidermal junction, many times the lymphocytes are associated with this vacuole actually. So that is the reason it is in the lichenoid pattern, because the inflammation is there, but it is not as extensive that you see in the lichenoid dermatitis. In lichenoid dermatitis, we talked about a dense infiltrate at the dermal epidermal junction. In this one, there is inflammation at the dermal epidermal, but very, very focal and mild actually. So you're definitely always going to see some lymphocytes at the dermal epidermal junction, and especially in those vacuoles. So that is another feature that you're going to read in the book. So that you see lymphocytes at the dermal epidermal junction in the vacuole actually. So you see that pattern, it makes it very easy that this is vacuolar interface dermatitis. And now what am I dealing with? You just pick up the phone and it makes your diagnosis much easier actually. And a fixed drug eruption, again the clinical picture is going to help you out. So what is a fixed drug eruption? In a fixed drug eruption, what happens? The patient develops a single lesion at some part of the body, common on the penis or on the genital area. Now, if the patient stops taking that drug, the reaction goes away actually. But the very characteristic feature of why is it called fixed drug eruption? Because if the patient after 6 months he takes the drug again, the lesion is going to develop in that same area again actually. So it's like a fixed reaction that occurs in the same place again and again. So that is the reason it's called a fixed drug eruption, not just a drug eruption. So most commonly it presents as a single lesion that happens in the same area again and again and again whenever the patient starts the drug, and then when the patient discontinues, the lesion goes away actually. So why is that important? Why is that history important? So again, like what do you see? Basket weave hyperkeratosis on the top. You go high power, you're going to see the vacuolar interface changes at the dermal epidermal junction with some lymphocytes that are like you see all these lymphocytes that are within the vacuole actually. So you see the same reaction pattern. You see some diskeratotic cells in the epidermis, and then you see this lichenoid infiltrate. Now, how do you make the diagnosis that this is not erythema multiforme, not graft versus host disease, but fixed drug eruption? So go back to the clinical picture that I told you actually. So this is a reaction that is happening at the same place again and again. So what happens is, because it happens very acutely, you are still going to see the same changes in the epidermis. But in the dermis, because it is happening at the same place again and again, the dermis tends to react in a different way. So what is the pattern that you're going to see in the dermis? You're going to see a lot of pigment incontinence. And why is that pigment incontinence? Because the reaction is happening in that same area again and again. So the dermis becomes more chronic. So in the books you're going to read, when they talk about an erythema multiforme, they talk about acute on acute. So what do they mean by that? Acute changes in the epidermis with acute changes in the dermis. And when they talk about a fixed drug eruption, they're going to talk about acute on chronic actually. So the epidermis is still showing you acute changes, but in the dermis you start seeing chronic changes. And what do you mean by chronicity? Is the dermis is more fibrotic, there's more pigment incontinence. So because it's reacting again and again to the same inciting agent actually. All the other features are still the same. Vacuolar interface changes, diskeratotic cells, and then the lymphocytic infiltrate. And because this is a drug eruption, you're going to see some eosinophils in the dermis. So if you see eosinophils in the dermis, you see pigment incontinence. If you see the diskeratotic cells in the epidermis, and then the pigment incontinence. You pick this is all the pigment. So this is highlighting the pigment incontinence, that is telling you that this is a chronic reaction actually. So you pick up the phone, you ask the clinician, what is the clinical presentation? And it's mostly going to be a big single lesion that is occurring at the same place over and over again actually. And if you have the clinical history, you think about it, You call the clinician up that I'm thinking of a fixed drug eruption. Is the clinical presentation compatible with a fixed drug eruption? And then you have your diagnosis that I'm dealing with a fixed drug eruption. Actually. What happened?
What about Staphylococcus syndrome?
We'll come to that when we come to the vesicular-bullous. So in the next reaction pattern, I'll show you a case of Staphylo. So remember, there is no necrosis in Staphylococcal scalded skin syndrome. It's a pattern of the reaction pattern of Staphylococcal scalded skin syndrome is a vesicular-bullous disorder. So this also looks like a vesicular-bullous disorder because the skin is sloughed off actually, but this is not a typical vesicular-bullous disorder. So when we come to the Staphylococcal scalded skin syndrome, we'll go back to the slide and compare them side by side.
Because they both have clinically the Nikolsky sign is positive, right?
Yeah, both of them have that. Because it's like, and what is that? That is common in a lot of other conditions. So like when you're pressing the skin, it gets sloughed off actually, and that is common in a lot of different conditions actually. What happened to this?
Were you trying to click the picture?
No, like I was just trying to move forward, but it is not.
Okay. Once it crashes again,
It crashed, it looks like.
Yeah, let's just go.
Yeah, I did the escape.
PowerPoint and then
Yeah.
skip to the next slide.
That's what I'm trying to do, but escape is also not working. Oh, there. Yeah. Okay. Okay. So we'll just keep we'll come to Staphylococcal scalded skin syndrome. So case 6. So this is very classic, a lesion that you see like atrophy in the central part of the lesion, some raised the raised borders, almost pigmented lesion, some follicular plugging. Lupus actually. So we are talking still like remember like I said, interface vacuolar changes, diskeratotic cells, no, not present, perivascular inflammation. If you see perivascular inflammation, you are dealing with connective tissue disease actually. So what are the features of a connective tissue disease? So let's first go back to the vacuolar interface. So again, like look at the junction. You see the vacuoles at the dermal epidermal junction. So that is, you are dealing with the vacuolar interface dermatitis. Do I see any diskeratotic cells in the epidermis? No, actually. So then you go, do I see inflammation in the dermis? Yes, there's a lot of inflammation in the dermis actually. So there's a lot of perivascular and periadnexal inflammation. So now you're dealing with most likely connective tissue disease actually. So what are the features? Follicular plugging. If you start from the top, you see follicular plugging, perifollicular inflammation, perivascular inflammation, vacuolar interface changes, dermal epidermal junction, pigment incontinence. So these are all features of lupus actually. So perivascular and periadnexal inflammation with vacuolar interface changes, you're thinking of connective tissue disease actually. So you do a PAS, so this is just highlighting the perivascular inflammation. So this is lupus erythematosus. So how do you sign this out? Interface vacuolar dermatitis with dermal inflammation compatible with discoid lupus erythematosus.
What about dermal mucin?
Yeah, that's what I'm coming to. So if you want to confirm that, the other two things that you can do is you can do a PAS to show the thickening of the basement membrane actually. So the PAS in connective tissue disease is going to show you this thickened basement membrane. So you can see that the basement membrane looks quite thickened, which is highlighted with the PAS. And then you can do a mucin stain to show increased mucin in the dermis. So those are the two things that you commonly see in lupus actually. So you're going to see a thickened basement membrane at the dermal epidermal junction, which you can highlight with PAS. And then you're going to see increased mucin in the dermis, which you can highlight with colloidal iron or Alcian blue stain actually. So you do those two stains, and then you are like then you know that this is most likely lupus, and then you advise the clinician to do serology or immunofluorescence to see if you have the lupus band test actually, and then they can confirm. In serology, they are going to do the ANA, the double-stranded DNA, and all the other markers. And in the immunofluorescence, they can do to see for a full house at the dermal epidermal junction. So by full house, you mean you see IgG, IgA, IgM, C3, everything highlighting the dermal epidermal junction. And that is the lupus band test actually. So other difference, so if you see a perivascular inflammation in the dermis, what are the other things to think of? Drug eruption, perniosis, and pleuris. So we'll come to that when we talk about the perivascular dermatitis actually. So case 7 is the one that we're talking about, the vesicular-bullous. So now we are moving on to the next reaction pattern. because otherwise we'll not complete today also. We'll have to rush. So this is now, what do you see here actually?
Separation.
Separation. So you're seeing separation of the within the epidermis. So this is one of the patterns of a vesicular-bullous disorder. So where is the split actually? It's in the epidermis. So whenever you see a vesicular-bullous disorder, the first question that you are going to ask yourself is, where is the split? So this is an intraepidermal vesicular-bullous disorder. If you look at this condition, so this is just a high power view of showing you the intraepidermal split of the vesicular-bullous disorder. Where is the split now actually? It is below the, so it is at the dermal epidermal junction. So in the first one you saw the split was within the epidermis. So that is an intraepidermal vesicular-bullous disorder. And if you see the split that is at the dermal epidermal junction, that is the prototypical part. So we call it subepidermal vesicular-bullous disorder. So that is how you're going to approach any vesicular-bullous disorder. So first, what is the question that you ask yourself? Where is the split? So once you have decided that this is, we'll come back to this later on. So once you have decided that, where is the split? Is it intraepidermal or is it subepidermal? So we'll talk about the intraepidermal split. So once it's an intraepidermal split, then you ask yourself, where is the split in the epidermis? Is it in the at the layer of the stratum corneum? So we talked about the normal skin. So this upper part of the skin is the stratum corneum actually. So in an intraepidermal split, where is the split? Is it in the level of the subcorneal? Is it intraspinous? So the spinous layer is the middle layer of the epidermis. So is it intraspinous or is it suprabasal actually? So those are the three levels that you're going to ask yourself actually. Is the split subcorneal? Is the split intraspinous? Or is the split suprabasal? So once you decide that the split is subcorneal, then your differential diagnosis is going to become very limited again. If you say my split is in the spinous layer, your list of differential diagnosis again going to contract to a big degree actually. And if you decide that your split is suprabasal, then your list of differential diagnosis is like 2 or 3 conditions. So you have to follow that pattern actually. Where is the split? Once you decided it's intraepidermal, where is it in the epidermis? So subcorneal, intraspinous or suprabasal. So if it is a subcorneal split, so this is the subcorneal split actually. So once you have decided it's a subcorneal split, your list of differential diagnosis is what now? Pemphigus foliaceus, staphylococcal scalded skin syndrome, bullous impetigo. That's it basically. Those are the 3 things that you're going to think of. Am I dealing with bullous impetigo? Am I dealing with a staphylococcal scalded skin syndrome? Or am I dealing with pemphigus foliaceus actually? So now, how do you differentiate between these 3 conditions? So in pemphigus foliaceus, what are you going to see actually? So here you can see that the split is at the level of the subcorneal, and you are commonly going to see these acantholytic cells. So these are what? These are cells, these are keratinocytes that have broken off actually. So and those are known as acantholytic keratinocytes. So you're going to see these acantholytic keratinocytes actually. And in the dermis, you're going to see a superficial perivascular inflammation with or plus or minus eosinophils actually. If it is a bullous impetigo, you're going to again see the split, but now you're going to see associated neutrophils within the split actually. So if you see associated neutrophil within the split with the acantholytic cells, you're going to think, am I dealing with bullous impetigo actually? And this was again, this is pemphigus. So yeah, let's go back. So sorry, this is all mixed up. So pemphigus foliaceus, I don't have a staphylococcal scalded skin syndrome in this lecture, but I'll tell you what are the features. So when you see the subcorneal split, so the main feature that we were trying to differentiate in was from toxic epidermal necrolysis. So this is what you're going to see in a staphylococcal scalded skin syndrome. You're going to see a subepidermal split, subcorneal split with no inflammation. So it's a very clean bulla that you're going to see at the level of the stratum corneum. So when you see a very clean bulla with no inflammation in the bulla, no necrosis of the epidermis, then you're dealing with staphylococcal scalded skin syndrome. But if you see a bulla that is subepidermal, so in the toxic epidermal necrolysis, the bulla that is not actually a bulla appears to be at the level of the dermal epidermal junction. So the entire epidermis sloughs up actually. And in this one, the stratum corneum is that is sloughing up actually. So you're going to see the stratum corneum that is sloughed off in staphylococcal scalded skin syndrome, and you're not going to see any necrosis or inflammation in staphylococcal scalded skin syndrome. And in the toxic epidermal necrolysis, it is the entire epidermis that is getting sloughed off, and you're going to see a ton of necrosis. And actually the entire epidermis is necrotic basically. So it's, once you know these features, it's going to be very easy to differentiate between staphylococcal scalded skin syndrome versus toxic epidermal necrolysis. And that is one thing that you have to know basically, even if you're not going to practice dermatopathology, or you're just going to send all your dermatopathology cases to somebody else to look at. But this can come as a frozen. So this is one condition that as a resident, when you finish up, you should be very clear that what is toxic epidermal necrolysis and what is staphylococcal scalded skin syndrome actually. So this could be either pemphigus foliaceus or it could be staphylococcal scalded skin syndrome actually. In the pemphigus foliaceus, you're going to see more inflammation in the dermis. In the staphylococcal scalded syndrome, most of the time there's no inflammation at it. It is a very clean epidermis, very clean dermis actually. And then obviously you're going to pick up the phone and going to talk to the clinician, like if you're, so intraepidermal split, subcorneal, your list of differential diagnoses is bullous impetigo, pemphigus foliaceus, staphylococcal scalded skin syndrome. For the bullous impetigo, you know you're going to see more neutrophils, and then if you do a gram stain, you're going to see more gram-positive bacilli cocci within the bulla. But for this one, you just pick up the phone, and pemphigus foliaceus and staphylococcal scalded skin syndrome are going to look clinically very, very different. The clinician is not going to say, my differential diagnosis is pemphigus foliaceus versus staphylococcal scalded skin syndrome actually. Clinically, they look completely different actually. So that once you talk to your clinician or your dermatologist, then the diagnosis becomes very easy, because now you already have a very limited differential diagnosis. You get some clinical input. Remember, inflammatory dermatopathology clinical input is very important actually, because you always have to do a clinical pathological correlation actually. Otherwise, you are just going to sign it out as subcorneal intraepidermal split, see comment, differential diagnosis includes, and that is not very helpful to the dermatologist. So it's better to pick up the phone, talk to your dermatologist, see the clinical presentation, and then give him a more specific diagnosis. If he's thinking pemphigus foliaceus, you can do an immunofluorescence, and you do the immunofluorescence, and it will tell you, because you're going to see the intercellular IgG at the within the, so you're going to see the intercellular IgG within the epidermis, you know it's pemphigus foliaceus. In staphylococcal scalded skin syndrome, it's going to be negative actually. That is another thing that you can do, but you don't need the immunofluorescence to differentiate between pemphigus foliaceus and staphylococcal skin syndrome. Yes, you need it to confirm your diagnosis of pemphigus foliaceus when you're thinking of pemphigus foliaceus, but to differentiate between staphylococcal scalded skin syndrome and pemphigus foliaceus, you don't need a immunofluorescence actually. The histology is very, very different and very classic for both of them actually. In pemphigus foliaceus, this is another thing that you should have to learn to recognize, because this is something that is easy to recognize and can be on your exams actually. So when you look at the pattern, this is known as an intraepidermal split, which is suprabasal. So you can see that the basal layer is preserved actually. So the basal layer is still hanging on to the dermis, and the rest of the epidermis is sloughed off actually. And when you read about this, they talk about this as a row of tombstones actually. So the epidermis looks like a row of tombstones. So this is like the row of tombstones that you see here, and the entire epidermis is sloughed off. And this is very classic for pemphigus vulgaris actually. And again, you want to confirm it, you do the immunofluorescence, you're going to see the immunofluorescence pattern actually. And what is the immunofluorescence? This is the immunofluorescence. This is another picture that you should recognize, because this is another thing that can come on your any of the exams that you give actually. So what is this pattern here? You see this chicken wire pattern within the epidermis, where the IgG and the C3 are highlighting the dermal epidermal junction. And this is very characteristic of all the variants of pemphigus. So if it is pemphigus foliaceus, pemphigus vulgaris, or the other variants of pemphigus that are there, all of them are going to show you a similar chicken wire pattern within the epidermis actually. So if it is a subepidermal split, so when it is, how do you think of a subepidermal split now? So once you decide vesicular-bullous disorder, subepidermal split, the next question to ask yourself is there any inflammation in the dermis, or is there no inflammation in the dermis? So if there is no if you don't see, so what am I talking about? So what do you have to go and look into in this area in the dermis and see if I see any inflammation or not. If you don't see any inflammation, your list of differential diagnosis again is very, very small. If you see inflammation, then we'll come to that. So if you don't, so this one is subepidermal split and no inflammation. So, and this is subepidermal split with inflammation in the dermis actually. So non-inflammatory, what is your differential diagnosis? So like this is very classic porphyria cutaneous tarda actually. So the first thing to think of is PCT actually. So subepidermal split, non-inflammatory, think of PCT, and the other, we'll talk about the features, and the other two things is cell poor BP and epidermolysis bullosa acquisitive. So EBA, cell poor BP and PCT. Those are the only three things that you're going to think of when you see subepidermal split, no inflammation. In PCT, what is the classic features that they talk about is one is festooning. So what do you mean by festooning? In what happens in PCT, the skin is very sclerotic. So the skin is very thickened actually. And because the skin is thickened, this dermal papillae, so this is actually a dermal papillae, and it retains its outline actually. So when the dermal papillae is retaining its outline, that is known as festooning. And then you're going to see some basement membrane material that is hanging from the roof of the blister, and that is known as caterpillar body. So you're going to, when you read about PCT, they talk about caterpillar bodies, so which is the remnants of the basement membrane hanging from the roof of the blister, and they talk about festooning actually. And the other two things that you need to think of is cell poor BP and epidermolysis bullosa acquisitive. So their list of differential diagnosis becomes very, very small. I'm not going to go into all these details of each diagnosis, but remember, you have to go through this algorithm in your brain, and the list of differential diagnosis is going to become very small. Now, if you see inflammation, the next question to ask yourself is, what is the kind of inflammation? Do I see a lot of eosinophils? Do I see a lot of neutrophils? If you see eosinophils, so your main diagnosis is bullous pemphigoid. So subepidermal split, ton of eosinophils, bullous pemphigoid. What are the other things that you need to think of? Bullous drug eruption, bullous arthropod bite, bullous wells, and herpes gestationis. So if you are putting the thinking cap on, remember the list of differential diagnosis is shrinking to a big degree actually. And then if you just have 3 or 4 diagnoses, ruling them out is very easy. If you're thinking of BP, do an immunofluorescence. It will show you the immunofluorescence pattern. If you're thinking of bullous drug, pick up the phone, ask the clinician, is the patient on some drugs which you think is causing? Bullous arthropod bite, it's going to be a single lesion. So once you have decided that this is what these are the main conditions that I want to rule out, picking up the phone, getting the history is going to be very easy actually. Herpes gestationis, is the patient pregnant actually? Is the patient young and pregnant? Otherwise, it's going to look very like classic bullous pemphigoid. But if you get a little more history, then you know this is a 34-year-old female. She developed this lesion. Histologically, it's looking like BP. Then it is not BP, it is herpes gestationis. So the history is going to help you out a lot actually. And then if you do the immunofluorescence, you're going to see this linear IgG and C3 at the dermal epidermal junction. If you see neutrophils, so this is, yeah, so like if you see neutrophils, then again now subepidermal split, neutrophil. So what are my differential diagnoses? Linear IgA vesicular-bullous disorder, bullous lupus, and DH. That's it basically. I'm not going to go beyond that actually. And always BP is always in the differential. For any subepidermal split, if it's cell poor, eosinophilic predominant, neutrophilic predominant, BP still is always in the differential. Remember that. So this is more almost neutrophils are actually there. So this is linear IgA vesicular-bullous disorder. But the other thing that you need to think of is bullous lupus. You do a serology, immunofluorescence is going to help you out. If it is DH, then it is more limited to the dermal papillae. If it is leukocytoclastic vasculitis or neutrophilic rich, bullous pemphigoid. So follow that pattern, and then your differential diagnosis is going to be much easier to come to actually. And if you can give the clinician a list of differential diagnoses, most of the times they can look at the patient and make up their mind, oh, I'm dealing with this condition actually. So case 9 is the next reaction pattern. So what is this reaction pattern? So now if you look at the epidermis, not much changes in the epidermis, but in the dermis you see inflammation in the dermis. So you go high power, you see this perivascular inflammation in the dermis. So you are dealing with perivascular dermatitis actually. So once you've decided that you are dealing with perivascular dermatitis, the next question, always follow an algorithm actually. Don't try to jump to diagnosis, follow an algorithm. What is the next question that should come to your mind? What is the kind of inflammation? It's always going to be lymphocytes. So the lymphocytes are always going to be there. But what are the other cell types that I see actually? So if I see eosinophils, your list of differential diagnosis again becomes very limited. Do I see a lot of neutrophils? Again, the differential diagnosis is going to. So you have to keep asking those questions to yourself when you're looking at a slide. Perivascular inflammation in the dermis, so perivascular dermatitis. Next question, do I see a lot of eosinophils? So yes, I see a lot of admixed eosinophils. So what is your differential diagnosis now? Drug eruption and arthropod bite or a prodromal vesicular-bullous disease actually. So the some people call it urticarial vesicular-bullous disease. So BP can present in the same manner without a split. Early BP can present in the same manner without a split. What tells you that this is BP? The same pattern actually. So inflammation in the dermis with a lot of eosinophils, but the split is not there. But more commonly, what is the main differential diagnosis? Drug eruption, arthropod bite. Those are the two main. So drug or bug, that's how they call it actually. It's either drug or bug. So either it's drug or bug, but the other thing that you have to remember, one other differential diagnosis that many people tend to forget is an urticarial phase of bullous pemphigoid, and that can actually present with just like a drug presence actually. So you'll have the perivascular inflammation with a lot of eosinophils. If the patient is old, you have to at least think that maybe this is BP, and the immunofluorescence might help the clinician actually. If the lymphocytes are predominant, so now you go down, you look at high power, you don't see any eosinophils, but it's completely lymphocytes. So what are the things to think of? Like we already talked about connective tissue disease. So if you are, then you have to go at the dermal epidermal junction, look for the vacuolar interface changes. If you see that, well, then I'm dealing with most likely connective tissue disease. The other thing that you need to know as a pathologist, one is EAC actually. So it's known as erythema annularis centrifugum. So what do you see in that? Superficial and deep perivascular inflammation, not much changes in the epidermis. Very characteristically, this inflammation is called coat sleeve inflammation. So like you have a coat sleeve, what is the characteristic feature of a coat sleeve? It is hugging your wrist actually. So the coat sleeve pattern means that the inflammation is like hugging the vessels actually. So it's like a tight coat sleeve around the vessels. So if you see an inflammation that is superficial and deep perivascular, composed predominantly of lymphocytes, you don't see the other eosinophils. And if you see this tight coat sleeve pattern, then you're dealing with EAC actually. And we already saw this slide. This is lupus. So it's perivascular and periadnexal with vacuolar interface changes. You're dealing with lupus. These are the other things that come under the perivascular inflammation, but we won't go into details because then it will not cover up all the reaction patterns. So this is actually pleva, but I'm not going to go into the details of pleva because we want to at least complete the reaction patterns. And this is perniosis. So now if you see neutrophils, so now again you're dealing with perivascular inflammation, but now neutrophils are predominant. Instead of lymphocytes, you see a lot of neutrophils. So perivascular inflammation in the dermis, you go high power, or it's composed predominantly of neutrophils. So what is the next question you ask yourself actually? So do I see any vasculitis? So the next question you're going to ask yourself is, do I see any vasculitis? So you go around the vessels and you look for vasculitis. If you don't see vasculitis, then this is like the prototypical lesion. So your perivascular inflammation in the dermis, quite very intense, composed predominantly of neutrophils actually. So if you see a predominantly neutrophilic infiltrate, this is neutrophilic dermatosis. So your list of differential diagnosis again is going to become very, very small actually. So the first question that you should always ask is, do I see any vasculitis? So you have to go around the vessels and look for vasculitis. If you don't see any vasculitis, this is, what is this condition called? This is the classic clinical presentation. So this is sweet syndrome actually. So neutrophilic dermatosis, the classic presentation is going to, the classic clinical presentation is going to be sweet syndrome actually. Again, you have to pick up the phone and ask the clinician, is sweets in your differential actually? Because there are other causes, neutrophilic predominant, no vasculitis, the main differential diagnosis is going to be sweet syndrome. There are other conditions that can present exactly the same way. So that is the reason the clinical input is very important actually. So pustular dermatosis of the dorsal hand, bowel associated dermatitis arthritis syndrome, rheumatoid neutrophilic dermatosis, pyoderma gangrenosum, all these conditions are going to present exactly the same way as sweets actually. So that is the reason you first have to decide what is the reaction pattern. Perivascular inflammation, neutrophilic dermatosis, And so this is the list of differential diagnoses that you can go through if you really want to go into the details. But if you don't want to go into the details, if you can still sign it out as neutrophilic dermatosis, most of the clinicians are smart enough to get to a diagnosis actually. So they know like neutrophilic dermatosis, my list of differential diagnoses is very small, and this is what I'm going to, but the important thing that you need to mention in your report is there is no vasculitis is noted actually, because if there's vasculitis, then the diagnosis goes on to a different algorithm actually. So if I see vasculitis, what is the definition of vasculitis actually? So when you're talking about tonsillitis, you're talking about any itis, inflammation, you're talking about inflammation of that organ actually. So tonsillitis is when you're seeing inflammation in the tonsils, or actinic cheilitis is inflammation of the cheilitis is inflammation in the lips actually. So we saw the neutrophils in the dermis actually. In the last one you saw the neutrophils, so there was inflammation in the dermis, but why is it not called vasculitis? So you have to remember in the skin, vasculitis doesn't equate to presence of a lot of neutrophils. The important thing to call anything vasculitis in the skin is this presence of this pink hyaline fibrinoid degeneration around the vessel. You want to see that before you call anything vasculitis. So this pink hyaline fibrinoid degeneration around the vessel with admixed neutrophils is the feature that you're going to see, you want to see to call it vasculitis. Just presence of neutrophils doesn't equate to vasculitis. You might see a lot of neutrophils around the vessel, that doesn't equate to vasculitis. All the other organs that will equate to itis. But in the skin, if you want to call it vasculitis, the important thing to look for is the presence of this fibrinoid degeneration around the vessel wall. So if you see that, then you know you're dealing with vasculitis. So if you see that, the other feature that you're seeing are this this blue dots that you see scattered throughout the dermis. You see all these blue dots. So these are nuclear debris that have broken off from the leukocytes actually. So that is the reason this is called leukocytoclastic. So leukocyte is a white blood cell, and the clastic means breaking up of the white blood cell, and that is the reason you see that the nuclear debris scattered throughout the skin actually, and then the presence of the vasculitis gives you the diagnosis. So most of the times you're going to just sign this out as leukocytoclastic vasculitis. That's it basically. You are not going to go into the etiology, because there are 1,000 things that can cause leukocytoclastic vasculitis, and you leave it to the clinician to decide, is it drug induced, is it related to some connective tissue disease, is it related to some viral infection, or is it idiopathic? That the clinician will decide. For as a pathologist, all you're going to tell him is leukocytoclastic vasculitis. That's it, and you move on to the next case actually. But you have to understand what are the features that will help you make the diagnosis of leukocytoclastic vasculitis. That should be very clear in your mind actually. So vasculitis, and this is how it is going to present clinically. So you see this purpuric lesions, and if you tell the clinician you're dealing with leukocytoclastic vasculitis, and he sees this, he can connect the 2 and 2 together and say, yes, I'm dealing with leukocytoclastic vasculitis, and treat the patient accordingly actually. And the other thing that you need to remember is this another reaction pattern that is important in vasculitis is vasculopathy. So I'm not going to go into details of vasculopathy, but what do you mean by a vasculopathic reaction pattern is when you start seeing a lot of thrombi within the vessels actually. So you see all these thrombi within the vessels, that is a vasculopathic reaction pattern, and it can occur in a lot of different conditions that are associated with coagulation disorders. So if the patient has any sort of coagulation disorder, what is the presentation that you're going to see in the skin? You're going to see all these vessels that contain a lot of this thrombotic material within them actually. So if you see this thrombotic material within them, you call it a vasculopathic reaction pattern, and that is seen in a lot of coagulation disorders. And all you have to tell the clinician is, I'm seeing a lot of thrombi within, or thrombotic material within the vessels, and it is compatible with any of the coagulation disorders that the patient can have. So important thing to recognize is this is a vasculopathic reaction pattern. That is the important thing that you need to recognize at this point when we're talking about reaction patterns. We could actually do an entire lecture on vasculopathic reaction pattern, but the main crux of today is to help you recognize all the different reaction patterns. So the prototypical thing that you're going to see here is this thrombi that you see in all the different vessels of the dermis, and you can highlight this with PS actually. So you can do a PS to highlight the thrombotic material, and if you see that, then this is a vasculopathic reaction pattern. And classic condition is cryoglobulinemia. Should I stop because it's already 9:05? There are two more reaction patterns there. Okay, I'll go a bit fast actually. So sorry. So this is the next reaction pattern where this is present as this annular lesion. So very classically, this will come in as rule out granuloma annulare. So what do you see in so granuloma? What do we see here actually? So what do you see here is this inflammation that is forming like a circle actually. So you see this inflammation that is forming a circle around this collagen material, and this circle is typically called like a palisade. So like what does a palisade mean? Palisade is a fence. So this is like a fence that is forming around this collagen material. So this this is known as a palisaded granuloma. So why is it called palisaded? Because it forms like a palisade around this necrobiotic collagen actually. So this is a palisaded granuloma, and if you go high power, what is it composed of? This is composed of macrophages actually. So you see a lot of macrophages and lymphocytes that are forming like a fence around this collagen material, and that is a palisaded granuloma, and that is what you're going to see in granuloma annulare. So this is just showing you. So if you look at the collagen here, this is normal collagen here. Here the collagen is a bit altered, and that is known as altered collagen or necrobiosis. You're going to read about necrobiosis actually. So if you do a mucin stain, there's going to be increased mucin in this area actually. So all these are macrophages. So a palisaded granuloma that is formed around necrobiotic or altered collagen is the classic thing that you're going to see in a palisaded granulomatous reaction pattern, and that is palisaded granulomatous dermatitis compatible with granuloma annulare. So the other condition that can show you the similar palisaded granulomas is NLD, which is necrobiosis lipoidica, rheumatoid nodule, and NXG actually. So I'm not going to, because we have shortage of time, I'll just show you that this is an NLD. In NLD, again, you see this layered cake pattern actually. So sclerosis, inflammation, sclerosis, inflammation, sclerosis, inflammation. And that is known as a layered cake pattern actually. And that is very classically seen in NLD actually. Again, the granulomas, you can see giant cells, granulomas that form almost like a palisade actually. If you go high power, you can see there's giant cells. In rheumatoid nodule, the same pattern, but in the lower part of the dermis. So the upper part of the dermis looks normal, but in the lower part of the dermis, you're going to see this. Again, you see this palisaded granulomas. You see this palisade. So this is formed around fibrinoid degenerated material, and this is the palisade actually. So high power view, palisaded granulomas. NXG also shows you palisaded granulomas. So this is again the palisaded granulomas. So if you see the palisaded granulomas, once you come to that reaction pattern, your list of differential diagnosis again is very short. Granuloma annulare, NLD, rheumatoid nodule, NXG. Those are the four things that you need to think of. So then it's easy to rule one in or rule the other out actually. So all the details we won't go into. So remember, the other granulomatous dermatitis, the other reaction pattern that you can see is sarcoidal actually. So in sarcoidal granulomas, you're going to see this naked granuloma. So when you read about sarcoidal granulomas, they're called naked granulomas. So what do you mean by a naked granuloma? Is a collection of macrophages that forms like a nodule, but very little lymphocytes actually. So the absence of lymphocytes is what makes it a naked granuloma. Because if you see a lot of lymphocytes, it's not a naked granuloma. So that is what they mean by naked granulomas. The absence of lymphocytes, it's all like a collection of macrophages. And that is classically sarcoidal. And then the other we talked about is the palisaded. And the last one is the foreign body granuloma. So granulomatous dermatitis can be sarcoidal, can be palisaded, or can be foreign body reaction pattern. And the last, no, this is not the last, second last actually. So what do you see here? Sclerotic dermis actually, a very, very sclerotic dermis. And this is actually morphia actually. So morphia is the prototypical lesion of a very sclerotic or fibrosing dermis actually. So what are the characteristic features? One is the shape of the biopsy actually. So if you look at the shape of the biopsy, what is the shape of this biopsy? Normally it's always wedge shaped. So normally what happens, the biopsy, if you look at it, it is going to be like this actually. All the other biopsy. This one is almost like a rectangle actually. So because the dermis is so sclerotic, it doesn't shrink actually. So that rectangular shape is one of the classic things that you see on a low power. And then you see the sclerotic dermis, loss of adnexa, and then you see this There's no adnexa here. And normally around these eccrine ducts, if you look at go back and look at normal skin, you're going to see fat around the eccrine ducts. So there is loss of peri-eccrine fat. So these are the eccrine ducts, and there is no fat around them. So that is another feature that you're going to see in morphia actually. And then if you go high power and look at the inflammation, you're going to see some plasma cells actually. So that is very classic morphia, and so morphia sclerosing disorders. Morphia actually. The other things that can show you similar reaction pattern is scleroderma, nephrogenic fibrosing disorder, and eosinophilic fasciitis actually. And the last reaction pattern, very classic. So where is the action here? So the epidermis looks normal. In the dermis there is some mild inflammation, but the main action is happening in the subcutis actually. And so this is panniculitis actually. So in the panniculitis, what are the two things that you want to look for? Is the inflammation limited to the septa, or is the inflammation going into the lobule? So if it is a septal panniculitis, so what do you see in this? You see a lot of inflammation in the septa, thickened septa, giant cells. So it's like a granulomatous inflammation in the septa actually. So this is erythema nodosum, panniculitis. So when the inflammation is limited to the septa, your main thing to think of is erythema nodosum. And when it is lobular, so this is a prototypical lesion of lobular panniculitis. So like when you're thinking of panniculitis, you should ask yourself, is the inflammation limited to the septa, or is it septal and lobular? So when it is septal, you think of erythema nodosum, and when it is lobular, yeah, so like erythema induratum, and then the other things to think of is lupus profundus, pancreatic panniculitis, alpha-1 antitrypsin deficiency, and subcutaneous fat necrosis of the newborn. So all these are like the same. So this is lupus profundus. I don't want to go into details. This is pancreatic panniculitis. This is alpha-1 antitrypsin deficiency, and this is subcutaneous panniculitis of the newborn. So what is the take-home message? You have to follow an algorithmic pattern, then and develop a list of differential diagnoses. If you do that, dermatopathology is not going to be that difficult, because then you're limiting yourself to very small number of differential diagnoses if you follow that pattern. And remember, there can be some overlap patterns. And then, like I keep stressing, you have to know to see the condition actually. And then it is not rocket science. The more cases you see, the better you're going to become actually. It's only like repetition that is going to make you a good dermatopathologist.
Thank you.
Sorry, I went over time here.
No, thank you. So we will let everyone know when we will have your next lecture. Thanks a lot.